Evaluation of weight regain, we have to go to basics. We have to evaluate the reason behind the regain, the reason behind the insufficient weight loss, and what was the reason behind this. Evaluation of the weight regain, we have to do a multidisciplinary assessment by psychiatry, endocrinology, and other comorbidities that the patient have. Pre-diabetic weight, it's very important to know. The BMI of the patient, excess weight loss, and the weight loss prior to surgery, if there is any attempts to lose weight prior to surgery. We have to do pre-operative counseling for this patient, procedure, and the dietary. If the patient is binge eating or not, is he grazing? If there is any alcohol or drug abuse, we have to do a support group for him at that time. Psychological state for the patient, hormonal and metabolic imbalance, there is thyroid or adrenal pathology. Questions we have to ask. What is the volume of intake that the patient is having now? And is there any change of the volume intake? Is there an increase? Frequency of meals that the patient is taking? Type of food, is he a sweet eater or not? Is he a quantity eater? Is there any GERD symptoms associated to his regain? Is he on new medications that induced weight regain for him? And how about his sleep? Does he have any sleep disorder? Is he taking any sleeping pills? We have what we can call it about resetting. I think this is a very important step we have to take if we have a patient with regain and we are planning to do we are planning for further surgical intervention with this patient. The pouch resetting is a way of returning stomach back to its size that it was immediately after surgery. Pouch resetting is non-invasive, safe, cheap, easy to be carried out. Resetting period usually lasts for about 10 days. What we can say more about pouch resetting plan, the first day we have to start them on a clear liquid diet, second day in a high protein liquid diet, second and third day, fourth and fifth we have to be in a pureed high protein diet, seventh and ninth day on a soft diet, and the 10th day will be on a regular diet. Revision surgery. Usually the revision surgery, if we are planning to proceed with the revision surgery for this patient, we have to know more about the patient anatomy. What was the primary procedure that he underwent, the comorbidities that he had prior to surgery, and does it resolve after the surgery or not? And the experience of the surgeon, of course, that's going to do the surgery for him. 15 to 30% of sleeve gastrectomy had an inadequate weight loss or weight regain and required an additional procedure. The additional procedure of sleeve gastrectomy usually due to pouch dilatation. The pouch dilatation could be categorized as primary and secondary. Primary dilatation is usually due to incompletely dissected posterior part of the gastric pouch, posterior fundus, during the initial procedure, which will result in a retained fundus. Or the patient was difficult, super obese cases, incomplete visualization of the left cross of the diaphragm, the learning curve of the surgeons. The secondary dilatation due to homogeneous dilated gastric tube, mechanism due to natural history of the sleeve, using a large calibration tube, patient's eating habits, a planned secondary procedure if the patient was planned for sleeve gastrectomy as a step-down procedure for the second surgery. Post-sleeve gastrectomy option. What is the option we can do if we have a regain patient post-sleeve gastrectomy? Pre-sleeve could be an option. However, it's carried out a lot of complication. One anastomosis gastric bypass is a valid option for the patient. Roux-en-Y gastric bypass, the older procedure, all of us, it's a very common procedure in bariatric surgery, mainly the first procedure in bariatric surgery. SADI, sleeve to re-sleeve, the mean operating time was longer, the post-operative complications higher. At 12 months, the excess weight loss was 66 for re-sleeve as compared to 77 in the primary sleep gastrectomy. There is an important thing we have to know, that the revisional procedure has carried out a lower excess weight loss than the primary procedure, achieve significant short-term weight loss, a slightly increase in perioperative complication. One anastomosis gastric bypass is a valid option, especially if the patient has no history of reflux. Better outcome in terms of weight loss than Roux-en-Y gastric bypass. More chance of malnutrition, especially if the BB limb is more than 2 meters. Sleeve to Roux-en-Y gastric bypass. Fourth international consensus stated that Roux-en-Y gastric bypass is an option if second operation is required for weight regain after sleeve gastrectomy. Sleeve to SADI, better weight loss with the peripancreatic diversion and edema switch, the expense of increased risk of vitamin deficiencies, no different in a short-term complication. Here is a paper. This is a recent paper published on April 2022. It's a meta-analysis. It's a systematic review that compared between 22nd studies for revisional post-sleeve gastrectomies. Of 22 studies, including 1,442 patients. 2 studies was reported on a new procedure, which is endosleeve gastroplasty, the gastric plication, the endoscopic gastric plication as revisional surgeries. 7 studies was on a re-sleeve gastrectomy, about 224 patients. 6 studies on Roux-en-Y gastric bypass, about 309 patients. 8 studies on one anastomosis gastric bypass, including 484 patients. 3 studies on SADI, including 150 patients. 1 study on duodenal switch. We can see here the follow-up post-operatively on 12-month and 24-month. In gastroplasty, there is a limitation in weight loss or decrease in the BMI, about 5.6, ranging from 5.6 to 5.9. On Roux-en-Y gastric bypass, ranging from 6 to 9. On one anastomosis gastric bypass, there is a significant decrease in the BMI, ranging from 8.3 until 17. In re-sleeve, there is also good outcome. But there is also associated complication, higher chance to get complication with the re-sleeve patient. And on SADI, there is decrease in BMI. However, there is more chance to have a malnutrition and severe vitamin deficiencies. Here is a diagram or a graph that showed each procedure with a curve on the dropping in the BMI along the 12 months up to 48 months. First one is the gastroplasty. We can see it's very limited and start to be fixed at a BMI of 32 or 33. The Roux-en-Y gastric bypass has showed a good decrease in the beginning, but patients start to regain after around about 2 years of the procedure, then it becomes fixed. The one anastomosis gastric bypass shows the best outcome an overall procedure with a good weight loss and better outcome and lower complication. The duodenal switch and the SADI showed a good result in the weight in terms of weight loss, but there's a high chance of developing malnutrition, vitamin deficiencies. Here is the complication that associated with each revisional surgery. The endoscopic sleeve, minor complication due to its an endoscopic intervention. The re-sleeve, it had around 8 patients with disease and 4 patients with stenosis. The Roux-en-Y gastric bypass had a high chance of nutritional deficiency. The one anastomosis gastric bypass shows the better complication compared with its result. Its complication was too accepted. The SADI and the duodenal switch shows a high chance of nutritional deficiencies. Here is the conclusion of the study, and what's the take-home message from this study? All reported revisional procedures result in a good weight loss. One anastomosis gastric bypass has a good balance between efficacy and safety. Duodenal switch and are associated with high complication rate. Literature is heterogeneous and has adequate follow-up. Here's another paper that supports the one anastomosis gastric bypass following regain after sleeve gastrectomy. It's a total of 56 patients underwent one anastomosis gastric bypass after sleeve gastrectomy. The average weight prior to one anastomosis gastric bypass was around 112. The minimum weight loss reached up to 85%. It shows that one anastomosis gastric bypass is safe, effective for weight regain post-sleeve gastrectomy. We can see here the weight before the primary sleeve, and sleeve down up to this point, start to regain, and then fall down with the one anastomosis gastric bypass. Indication and outcomes of conversion of sleeve gastrectomy to Roux-en-Y gastric bypass. It's a systematic review and a meta-analysis. About 17 unique studies around the number of around 565 patients. The meta-analysis showed that the conversion from sleeve gastrectomy to Roux-en-Y gastric bypass is a good option for conversion of bariatric surgery, bariatric care center that produce a sufficient weight loss outcomes and potential resolution of symptoms of GERD. Further indication based on studies and are required to be obtained clear consensus and surgical management of patients seeking RYGB following sleeve gastrectomy. Now I'll go into more about complication of sleeve gastrectomy. The complication of sleeve gastrectomy, as we know, leak is the most common, one of the most common complications post-sleeve gastrectomy. A stable line leak is rare, but fatal complication following sleeve gastrectomy. The incidence of leak is ranging from 0.5 to 5.8. They most commonly occur during the gastroesophageal junction due to a narrowing at the level of the incisura angularis that will end up a high back pressure flow, will end up with a leak in the gastroesophageal junction. Patient will present usually with a sepsis sign like tachycardia, fever, sudden changes in abdominal pain, require a high clinical suspicion of leak. CT and upper GI fluoroscopy are the imaging modalities. The first step is a treatment of the sepsis with antibiotics, IV hydration, keep the patient MBO. We have to think about the endoscopic management for this patient. If the patient is severely ill or critically ill patient that he's unstable to undergo the endoscopic management, we have to take patient direct to OR for a lavage drainage. Usually the stitch at the site of the leak is not a valid option for these patients. We have to control the sepsis, place a drain per patient for endoscopy for possible stent placing and further management. Literature report wide range of fistula closure and need for operative intervention. The average duration to the resolution of the leak is about 40 to 61 days, with some data to suggest earlier resolution if operative intervention is more aggressively selected. Rates of operative intervention for a leak vary widely from 24.7 to 27.4, to 61, and are often determined by the surgeon preference for operative intervention or conservative management. Conversion to Roux-en-Y gastric bypass performed as an initial treatment for a leak or as a later procedure in a patient with a chronic fistula that has failed treatment modalities. A proximal leak near to the gastroesophageal junction have more difficulties for healing and may require conversion to Roux-en-Y gastric bypass, although alternative the creation of Roux-en-Y fistula jejunostomy. This is a paper for the use of endoscopic stent and management of the bariatric complication. The algorithm here, we can see there is an post-op. We have a stable line leak or an anastomosis leak or stable line leak, the post of day one with a septic shock, we have to go with a surgical intervention with a stent patient. If he's an outpatient, we can place an endoscopic stent patient. The anastomosis stricture or sleeve stricture unable to pass scope prior to dilatation, balloon or American dilatation with endoscopic stent, able to transverse stricture prior to dilatation, no stent could be placed. Gastrogastric fistula, index of operation less than 6 weeks, we can do stent for them. More than 6 weeks, they have to go to undergo the surgical management. Bleeding after sleeve gastrectomy could be intraluminal or extraluminal. Bleeding is usually found at the stable line, also can occur on the spleen, short gastric, liver, size of adhesiolysis, or abdominal wall. The incidence of bleeding around from 0.6 to 2.7. If there is a concern of bleeding, a physical exam and serial serial exam and the complete blood count could be done for the patient with a serial CPC. Unstable patient should return to the operating room immediately. Stable patient can be managed conservatively with fluid resuscitation and serial hemoglobin monitoring. If the source believed to be intraluminal, management should be with the upper GI endoscopy and upper GI protocol. Stricture of the gastric sleeve can occur post-operatively with reported incidence between 1.1 to 3.5. The symptomatic patients classically present with nausea, emesis, abdominal pain, and dysphagia, creating a narrow sleeve or poor stable line alignment or angulation at the level of incisura angularis, over-aggressive suturing of the stable line, unintentional rotation of the stable line anteriorly or posteriorly could end up with stenosis and twist. Stenosis can develop other complications such as leak, as we said before. In symptomatic patient, endoscopic intervention is the cornerstone management. Endoscopic dilatation success rate is about 83 to 90%. If symptomatic stricture with obstruction persists, conversion to Roux-en-Y gastric bypass is the option. Here we have I have a video for a patient that underwent sleeve gastrectomy 10 years ago, and she came back to my clinic with a history of stenosis, nausea, and vomiting. I attempted to do an upper GI endoscopy for this patient, which shows a twist at the area of the incisura. We can see here is the twisted part at the level of the incisura. So when I'm creating the pouch, I have to be above to this area, so I can bypass the area of stenosis or stricture. So after resecting the pouch, after resecting the pouch, we can see here is the twisted part. Came to be twisted again. So this was the reason behind the obstruction, that the gastric outlet obstruction that the patient had, due to the narrowing at the level of the incisura angularis. So this patient underwent I did a Roux-en-Y gastric bypass to bypass this area with a small gastric pouch. Okay. GERD, de novo GERD, or exacerbation of pre-existing GERD, became the Achilles heel for sleeve gastrectomy. A recent meta-analysis reports about 23% incidence of de novo GERD symptoms and 6.8 for a long-term prevalence of Barrett's esophagus after sleeve gastrectomy. This is likely caused by a change in the pressure dynamic in the gastroesophageal junction with the blunting or removal of the angle of Hess. Workup of GERD post-sleeve gastrectomy similar to patients without previous surgery and should undergo upper endoscopy, 24 pH monitoring, and barium swallow, esophageal manometry. Surgical intervention can be offered if there is anatomical complication from sleeve gastrectomy. Here is a large meta-analysis that speak about, does sleeve gastrectomy expose the distal esophagus to sleeve reflux? The postoperative prevalence of GERD esophagitis and Barrett's esophagus following sleeve gastrectomy is significant. Symptoms do not always correlate with the presence of pathology. As a result of uptake from sleeve continue to increase. There is a need to ensure the surgical decision-making and the consent process for this procedure. This study including around 10,718 patients post-sleeve gastrectomy. So the take-home message for us, primary surgery has the best chance for weight loss or excess body weight loss. We have to define failure very properly with our patients. We should not jump to revise procedure prior to understanding the reason behind the weight regain for these patients. And we have to do proper evaluation for our patient prior to go for the next step or next surgery. Thank you.
Thank you, Dr. Aziz, for the excellent lecture. We'll keep the question and then. Hello, good evening, everyone. I would like to welcome Dr. Abdul Rose for the second presentation today. He is a consultant and head of bariatric, metabolic, and minus surgery in Kinka University Hospital. And he is also assistant professor at Imam Abdul Rahman bin Faisal University. He has in-house surgery for clinical fellowship in bariatric and metabolic surgery at Strasbourg University in France. And also he has clinical fellowship in advanced colorectal surgery at University of Montreal in Canada. He's going to present today revision of 1Y gastric bypass for weight gain and complication. So, the mic is yours.
Thank you for this kind introduction. So, I thought it's going to be more precise, hopefully shorter, smaller than the previous topic, inshallah. So, revisions after 1Y gastric bypass. So nothing is disclosed. So before we start, we have to know what does revision mean. Revision can mean multiple things. Subdividing them into three subjects. Conversion. Conversion is when we change a type of surgery to another different type of surgery, from restrictive to malabsorptive, from malabsorptive to restrictive, or another malabsorptive surgery. Correction, we say the same surgery, we just correct whether the complication or the inefficiency of this procedure. Reversal, as we all know, is just restoring the normal anatomy after this bariatric surgery. This is a table showing the different types of surgery in the United States within the last 10 years. As we can see, sleeve gained more patients throughout the years. Bypass went up, then down, and it's coming back again. But what I want to concentrate on the revision, it was 6% in 2011. And now it's reaching almost 17% in 2019. So the revision cases are booming in one way or another. So what are the reasons of revision? Also, we can divide them into three subgroups. Insufficient weight loss, we can define them as a BMI more than 35 kg per meter square after 18 months of surgery, or less weight loss, less than 50% of the excess weight loss after one and a half year. In case of severe nutrition or metabolic complications, this is also a cause of a reason for revision. Third reason is intolerant side effects and mechanical complications, like Dr. Aziz just said earlier, leaks, stenosis, torsions, reflux, skin diarrhea. And this third reason is becoming more and more, unfortunately, what we see in our hospital. So one thing that we have to explain to our patients that excess weight loss after revision surgery, it's not like the primary surgery, it's much less. They have to understand this thing. Restrictive plus malabsorptive procedures are the best option after weight failure. It's better than restrictive procedure. Example, re-sleeve. I really don't believe in it. I think jumping to a malabsorptive surgery is better in case of failed sleeves. Revision of failed restrictive operation to Roux-en-Y, single anastomosis, or DS usually has the best, DS, the zone switch, has the best success rate after failure of primary bariatric procedures. So what type of revisions can we do for Roux-en-Y gastric bypass? We have multiple options. We can start with endoscopic revision, sclerotherapy to decrease the gastrojejunal stoma size, adding an adjustable gastric band, gastric pouch resizing, conversion, the bypass to a distal bypass, which is what we know as BP distalization or alimentary or Roux-en distalization. Conversion of surgery to another malabsorptive surgery, to a duodenal switch, or a Scopinaro or a SADI procedure. Candy-Cane syndrome, or reverse it to normal anatomy. We're going to concentrate mainly on two things: gastric pouch resizing and conversion to a distal gastric bypass. So in a survey published recently, this survey involved 460 surgeons from 62 countries. They asked them what kind of surgery, of revisional surgery, would you choose for your patient after a Roux-en-Y gastric bypass. 50% of the patients, the surgeon said, I would do just simply a pouch resize. Number one. 30% of the surgeons, they said, I will do just a prolongation of BP limp. 26% they said they would change or decrease the stoma size of the gastrojejunal anastomosis. So once again, we will discuss the first and the second most common choice. The first consensus statement for revision and bariatric surgery using a modified Delphi approach. This is a big study involving 70 revisional bariatric experts from 27 countries. I believe Dr. Khalid Mirza was one of them. They reached an agreement that in revisional bariatric surgery, the best option for a Roux-en-Y after a failed Roux-en-Y gastric bypass or one single anastomosis Roux-en-Y bypass is to make an elongation of the biliary-pancreatic limb. They also suggested that any kind of revisional surgeries should be done by an expert bariatric surgeon in an expert center, in a high-volume center. And always, when we're doing a revisional surgery, we have to count or measure the complete length of the bowel. So the primary Roux-en-Y gastric bypass, as we know it, we have 3 limbs. So this is for our young surgeons on the table, Dr. Mu'taz, Dr. Naif, Dr. Anas. So we have elementary limb. Usually it's 150. This is in case of a long elementary limb. The BP limb, usually it's 50. It can range up to 100, so it depends on the surgeon. Then we have the common channel, which goes unmeasured most of the time. Our total elementary limb length is our elementary plus the common channel. Okay. So this is what I usually do is 150, 70. Some surgeons, they do the inverse. They do 150 BP and elementary 70. Some surgeons do 100. So it depends on the school of the bariatric surgeon. So distalization of the bowel loops. How many types do we have? So we're going to talk about the main 2 types. So first type is when we elongate the BP limb. The second type, we elongate the elementary or what we call the Roux limb. So the first type is called the Sugarman distalization. What is Sugarman distalization? The jejunal anastomosis is taken down at the elementary limb and re-anastomosed more distally, around 150 centimeters proximal to the ileocecal valve. By doing so, what do? The elementary limb stays the same, but the BP limb becomes longer. The common channel shorter. The total elementary limb becomes shorter. So more malabsorption, and the patients start to lose weight. Just a diagram to show what I just talked about. So this is our normal Roux-en-Y bypass. So we cut at the elementary limb, and we do the anastomosis more distally. So the BP limb gains more length. So the BP limb becomes longer, the elemental limb the same. It might lose 5 centimeters, but not a big deal. The common channel becomes shorter because it loses some length to the BP limb, and the total elemental limb becomes shorter. And this way, the patient starts losing weight. The second type of distalization is called Brolin distalization. What is Brolin distalization? It's the same thing. We cut the jejunal valve, but this time at the BP side. And we re-anastomose it more distally, around 75 to 80 centimeters proximal to the ileocecal valve. By doing so, the elemental limb becomes longer, the BP limb unchanged, the common channel is shorter, and the total elemental limb is unchanged. Again, a paragraph to show what we just talked about. So the BP is cut, moves more distally. The elemental limb becomes longer. BP limb unchanged, the common channel becomes shorter. So more malabsorption, and the patient loses weight. So type 1 or type 2, Sugarman or Brolin distalization. Whatever we choose, we have some basic concepts we have to stick to. To show you what I'm talking about, this is a systematic review conducted by 21 studies. The objective is to see the role of the total elementary limb length. They concluded that if we have a total elementary limb less than 4 meters and the common channel less than 2 meters, there is a big chance they can reach up to 63% that the patient will go into severe malnutrition and he will need revisional surgery to adjust the length of the bowel. So the conclusion is, whatever type of distalization you choose, you have to have at least a total elementary limb of 4 meters and a common channel of at least 2 meters. Some surgeons go to up to 2.5 to be on the safe side. In a randomized controlled trial recently published in obesity surgery, comparing the two distalizations, almost to the somewhat to distalization. So we have the long BP bypass with a BP of 150, elementary limb of 75, comparing a short limb gastric bypass. What do we mean short? The short BP limb and long elementary limb. They found that, yes, patients with a long BP limb, they lose more weight, starting from 9 months onward, but it is more significant, but 81 to 71%, it's almost the same. At what expense? This is what another study showed us, that patients with longer BP limb, yes, they might lose more weight, but at the expense of having more vitamin, iron, mineral deficiencies, vitamin D deficiencies, parathyroid, iron, ferritin, hemoglobin, and other mineral deficiencies. So it's a matter of balance. You can lose, yes, more weight, but at the expense of some deficiencies. What about the first option for surgeons? They said they would do a gastric pouch resizing. Yet lots of studies show that a smaller gastric pouch has a faster gastric emptying. What does it show? That what does it give us? A faster gastric emptying. Faster gastric emptying is associated with a greater weight loss maintenance after bariatric surgery. Another big study from the Scandinavian registrar, almost 14,000 bariatric Roux-en-Y gastric bypass patients on the side of the gastric pouch. So their mean length of staple use was 145 millimeters. So they measured it interoperatively, how many staplers or reloads they use. At 1 year, there was almost 0.9% ulcers or anastomotic ulcers. There was a relative risk of marginal ulcers that increased by 14% for each centimeter of staple line. So each centi of staple line, you're increasing the risk by 14%. So their conclusion is a smaller gastric pouch decreases the risk of marginal ulcer, which we all know. This is a small, one of my patients that came to me. She's a 60-year-old female physician. So physician is very important. So she has to understand the procedure and the consequence of the procedure. Diabetic, hypertensive. She had a gastric band in 2010 with a BMI, it was 52. Removed the gastric band 5 years later, stayed still obese at 47, Roux-en-Y in 2017, her BMI was 50. She came to my OPD with a BMI of 42. So still morbid obese, still hypertensive and diabetic. Full endocrine investigation was normal. Endoscopy showed a small gastric pouch around 30 millimeters. So no maneuver here to decrease the gastric pouch, with no other pathology in her gastric pouch. Gastrografine, the same thing, a small gastric pouch. So we went in, severe adhesions, which is obviously, this is the third divisional surgery. So importantly, we have to do a complete adhesionolysis, not partial complete, because like we said, it's very important to do a complete count of the entire bowel. So even the bowel adhesions were so severe, it took us almost 2 hours just to see the normal anatomy. Okay. After that, like I said, precise measurement. I insert a sterile ruler to have an exact measurement of the bowel. Each centi is very important in revisional surgery. So we measured the entire length of the bowel, and then we did a new alimentary limb. I did for her a Sugarman distalization, a BP limb distalization. And at the end, also, we closed the mesenteric defect to prevent any internal hernias. This is a non-absorbable V-lock. The recommendations are to use a non-absorbable suture. So in this patient, intraoperative, we found that she has an alimentary limb of 150. Her BP limb is 60. The common channel was almost 370 centimeters, and the total alimentary limb was 520. So we did the Sugarman distalization. Her alimentary limb stayed the same. We added 1 meter to her BP limb, so to 160. The common channel decreased another meter. We lost a meter, and the total alimentary limb also lost a meter. So we had a total of 420, common channel of 270. It was 4 months back. I saw her today in the clinic. Her complete blood work are normal. She lost almost 12 kg, modest loss of weight, but I explained for her, any revision surgery, the weight loss is going to be a bit slower and maybe less than a primary surgery. Second case, 38-year-old. This guy is socially and he was a bit, I'm not going to say highly educated, so this is a very important issue. Hypertensive, dyslipidemia. He had a rheumatoid gastric bypass in 2013. The lowest BMI he reached was 34. After the pandemic, he continued to increase in weight, and he came to my OPD with a BMI of 37, still hypertensive, uncontrolled hypertension. We did an endoscopy, which showed a large gastric pouch and a long blind bowel loop, which we call a candy cane loop. So the same thing, lots of adhesions. This is his gastric pouch. I don't know if it's clear or not, but he had a relatively big gastric pouch. Okay, and here I'm just showing the resonance where we're gonna cut. We inserted a 36 French bougie. And this is his candy cane, which was almost reaching 10 centimeters long. He was also complaining of very bad breath. So resection, we cut his candy cane and we did a gastric pouch resizing over the 36 French bougie. And the methylene test was done, negative. And unfortunately, didn't put the gastrography study post-op, which shows a very small gastric pouch, which we were satisfied. So intraoperative, what did we found? We found that his alimentary limb is 150. He had a BP limb of 120. So a very long BP limb also. Common channel for around 2.5 meters and a total alimentary limb of 4 meters. So we decided not to do anything with the bowel, no distalization, just go with gastric pouch resizing. And like I said, he wasn't a highly educated patient, so any maneuver to distalize his bowel, he's going to need continuous monitoring, lab works, so we avoided that dilemma. So the take-home message, distalization after Roux-en-Y bypass is effective. Type 1 distalization is more effective than type 2. However, type 1 carries a higher risk of protein and nutritional deficiencies. the total elementary limb length should be at least 4 meters, and the common channel should be at least 2 meters when doing any revisional surgeries to avoid any protein or vitamin deficiencies. Pouch length or size, if you're going to measure it, you shouldn't exceed 145, 150. That means 3 reloads, including the horizontal stapling. So one horizontal, you either do it 45 or 60. You have to keep counting not to exceed 150 millimeters. Otherwise, you'll not lose that much weight, and the higher risk he's going to have an ostomatic ulceration. And remember that any revisional surgery is very risky. We have scars, we have inflammation, we have adhesions. This is going to render the surgery more difficult, more risky, more complicated, hopefully not, but more complications are at risk, longer operative time, and the conversion to laparotomy is going to be higher. Thank you.
Thank you, Dr. Abdi, for such an informative presentation. And thank you also for being on time. I think still we will keep that question and then the following discussion session. Thank you to our sponsor. Again, present for us.
Hello, everyone. My name is Fatima Khamis, and I'm from EBSC company. It's my pleasure to be with you. Thanks. It is my pleasure to be with you here today. As you know, EBSC is one of the biggest company, and we provide a lot of service. And one of our service it is provide oral nutrition supplements. And we have a lot of our protocol. We have a lot of oral nutrition supplements for diabetes disease and for kidney disease and for pulmonary disease, and also for post and operative oral nutrition. So today I will talk about one of our products that it will be help pediatric patients. Our product is called EnsureMax protein. EnsureMax protein is served with 30 grams of protein. As we know, patients after bariatric surgery need a lot of protein to help hormone healing and to prevent losing hair. So a lot of the adequate protein in EnsureMax, it will be help the patients. And it is low in carb. It came with 150 calories and 1 gram of sugar. And also it came with 25 vitamins, and the vitamins is calcium, and it's very important for bariatric patients. EnsureMax, it came with 3 flavors, chocolate and mocha and vanilla. And you can find it in marketplace and Nehdi Adela, and it's available at South African Hospital and also in Masa. And you can take it from a debit now in Thailand. So that's it. Thank you very much.
Thank you very much for the moderators. Thank you very much for the presenters for such an informative session. That was very interesting. I'm pretty sure there will be a lot of questions. We'll be taking questions from the presenters next, or whoever has a question. I'm going to walk to the person and take who to ask first. Okay, or we have Thank you for both of you. Great presentations. I would like to emphasize on one issue for sleep gastrectomy and for people who develop reflux after sleep gastrectomy, what we call the long group. And some other people that have reflux but not as symptomatic as post-op will become more symptomatic. So we have seen many of those people. If the BMI is normal and you don't have to go to the lower gastric bypass because they have a normal BMI, we can offer an endoscopic procedure that works very well in those cases. The reflux procedure, and it gave very good results. We're talking about positive field. However, it had very good outcome also in the primary reflux cases without the but especially positive effect of it works very well. I am ready. I am presenting. Strep down reflux procedure. This is a radio frequency ablation at the level of the GE junction. It will work at 6 levels. 4, the level of the lobes of the GE sphincter, and 2 levels at the level of the cardiac. And a circumferential way to increase the muscle thickness over 3 to 6 months. You can see the maximum effect in 6 months, but in average, over 2 to 3 months, you will have a very good effect. And the patient will start feeling this after 4 weeks. I can present on the topic about it.
Dr. Khalid seems to have a comment. Regarding the pathophysiology of reflex process, the historically different due to distant extraction, due to nerve. This is like we have. So if you do ablation, and I don't know how many cases you have good study about this and how much of the outcome, but the pathophysiology totally are not seeing and how it work prevent the reflex. If you allow it, because
I think so. First of all, regarding social reflux, no, I disagree that it's always due to stenosis at the level of the SU2. We can have reflux independent of any stenosis at the level of the SU2. But there are cases, as you have said, here we have a difficulty, and that's we do reason why I have a similar. However, how it works, which will be, whatever I will say, how it will not be enough. I have to send a doctor.
what do you mean that we have
We don't do it. We don't do it. No, we don't do it. It's contraindicated.
The normal is to do some surgeons do anthem preserving you get actually don't have the anthem, they are very wide still they have a high pressure valve, something high pressure valve. The best option is just switching from a high pressure valve to a extremely low pressure valve. What best surgery is to do is what open wide. And another benefit is to train to open wide, and 30% of patients after sleep, they become complete after 5 years, they get the extra weight. So doing so, we also try to give them a heads up not to increase their weight. So bypass, we're solving the reflux and preventing them from being moved in the future. But interesting option.
Thank you very much for the speaker. You can share to allow me to speak for this moderator. Maybe my comment will be a little bit from if we give me the chance to comment. First, and original we have to ask ourselves before we ask our patient what is the long term for the second procedure. Is the procedure that we will select for your patient after 3 years, 4 years, the patient will regain weight, and how much the percentage of the regaining weight after the revision. In some cases, it will be endless. If you change the brain transplant the patient, but very careful to select your procedure, not only in the long term, also you have to put in consideration the quality of the life that you will provide for your patient. Very important also You don't have, okay, skinny person and at the same time a very weak person, prostate is dead. This is very important. And don't create a complication to create another complication. So it is very important when you want to discuss and you want to select your second question. For that reason, we ask ourselves, we go to the literature for some related position, for example, for these three. First, are you obeying the patient wish? If you are obeying the patient wish, so you are in big trouble. We shouldn't consider this in our practice, but we didn't look for the result. Or the second complication we have for the patient for this procedure, even we have okay, now there is a revolution and a endoscopic management, but is the endoscopic management a base of long-term result? We don't consider. So we do simply the proper procedure for patient caring after adequacy, not working after sleep or after the but in my personal experience, it was in 2005, talking to regard to safety for last 15 years, I found obviously that the two options for me is either many just bypass with restart or one just and in this we presented in the first post meeting in Kuwait 2013. I think presenting the vision of sleep to move bypass, and there was a controversy as most of the surgeons and they just the God, the representation of Europe, especially stimulate and the measurement of the way of the small intestine and the measure of the weight loss problem wasn't good, but the nutritional deficiency is better. So we believe in the either medical part or problem because the first rule in this position is restricted number one and put it mind absorbed number two. So no revision, for example, in both from sleep to open mind or to medical path, you don't do deciding of the function. This is my first one. I'm proud that I see your work, but that I'm wishing you the best as now you are in the beginning of the career as pediatric and provisional surgery. But as an order, I'm pass on to them to young observant. In last month, in ASWS meeting, I presented and the positive publication of the vision of broken one very fast and we compare for surgical technical and outcome over since we started the vision of broken one very fast because the first 6 years was to the primary remote one, but we started to revise broken one fast in 2011 and now we predict 98 cases of revised broken one very fast and going to be published. And we divided this period from 2011 to 2015, and we did about 32 cases. And from 2015 till the end of 2022, and here was the big volume of revised clinical paths till we reach the current. We compare for procedure and we conclude at the end of the last 4 years. We are not anymore doing this sterilization, doing presentation about sterilization. We don't do now anymore this sterilization. This is by parts, giving common level 2 meters. This is very accurate, absorbed, and not only this, the weight lost after the initial eating one. Not more than 7%. And if your patient comes to you with BMI 44, so it will be ended with BMI of 37. So still it is more difficult. In addition, this is our outcome of follow-up overviews. Actually, the best procedure in our hand, but unfortunately, because an unavailability in the market, when we do banded exercise, banded by class with elongation, not the sterilization, we measure all the lengths of the intestine, of the treatment of fish, the reducing absorption, because there is even an empirical variation between human being and human being. Some people actually created or had a form with simple meter small numbers. So we have the formula how much you create for an absorption. And now we keep all of them form. We will do the irrigation, sorry for the we do the irrigation and increase very fastly. Restarting along the 7% reduction from the second peak mark. Restarting with the irrigation is rise the percentage to 10%. Until this point we will reach to 30. Banded gas, banded after restart and irrigation, the building created, we reach to 13%. And thank you very much. I thought that it came out of the time.
Well, thank you. I think if you give a good idea on how there should be a session, a debate session, not a presentation. Maybe that's a good debate session. We'll take one more question this time, please. No comments.
Yeah, amazing presentation. Both I like a lot because you included the most recent picture. And I'm just going to give you case for each of you. And I'd like to know how you deal with it. I think Hafid did an amazing presentation when we stressed the idea of the sort of elementary length of 4 meters. But I'm going to give you a case. Assume you did a case and you measure the bowel length and you find the equilibrium between this 50 centimeters, 7 centimeters, and the total length is about 9 meters. Would you still want to do 4 meters, or how would you deal with it? That is the question for you. Think about it and tell, because I'm still figuring out these answers because I've been doing this for 20 years and every year I change my opinion about the guy trying to reduce the malnutrition. For Abdulaziz, my question to you is, let's assume that the patient of the BMI 40 began and came up to a BMI 40 has no problems, so not fluid intolerance, no state and is asking you what would be the ideal procedure for me, so there is no undecided on how would you go for a and that's the question or and what would be the living length between or either of these? Thank you.
Yeah, regarding the hydrogen, of course, the best option to go with the 1.5 more gas for many gas with a big limit of 2 meters. Putting in our mind that the patient has no history of reflux and is not complaining of resistant care symptoms. So this would diet would be strong point with us to go with the 1.5 more gas for some. If there is a strong history of reflux or they have a related head, that at that point my mind will be changed with the whole my gas bypass and here is to prevent any chance for further infection. So 1.5 gas bypass is the ideal option. So we will measure the whole thing. I'll measure the region of 2 meters and you will not measure the whole no.
But for the 9 meter valve, what I've seen with my seniors, my consultants, one surgeon they will say yes, we will maintain 4 meters total internet, and the rest we're going to be BP and rural net. The other thing they said, no, we have a rule with 1/3, 1/3, 1/3. 1/3 BP, 1 elementary, 1/3 standard. So for the time being, I've never had 9 meters, but I think I will stick with the 4 meters at least the total implement, and at least that is 2.5 meters of common channel.
Well, thank you for this, as I said, very informative session. I definitely learned a lot. And thank you for everyone who attended. Thank you for all the moderators. Thank you, Dr. Ayad Al-Qahtani, for listening to us. And hopefully we'll see you again next month. And good night. Okay. Just a last notice, if you did not register, please scan your barcode and register for the CMEs.